Before I start, I want to give a big thank you to the Elton John AIDS Foundation, which made this report possible and has been our partner in the process. Thanks very much to the foundation. Also, many thanks to Mike Isbell, who played an integral role in report research and writing. Please put any questions or comments you have at any time during the webinar in the Q&A box, and we'll get to as many of those questions and comments as we can. And you'll see now the report link is in the chat box. With that, let me hand it over to Anjali for introductions.
Terrific. Thank you so much, Chris. And it's great to be with all of you today to launch this report. Let me start by saying that the HIV response is one of the most consequential responses of all time. Not only has it driven the HIV impacts that we've seen around the globe, but it's also driven broad-based health gains, which this report highlights and features. The global response to the HIV pandemic over the many decades has brought to the world many, many lessons. It has showed us the power and effectiveness of multi-sectoral responses when we work across the whole of society with ministries of health, ministries of gender, ministries of finance, ministries of social welfare, and more, with communities at the center, a whole of society approach. The global HIV response has shown us the power of and importance of high-level political commitment. We've seen over the decades highest levels of states, heads of state coming together to focus on this issue. We've seen unprecedented resources being mobilized from all over the world to support the HIV response. We've seen investment in research and development of products and solutions, making drugs and other commodities and other solutions accessible to everyone around the world and affordable so that people everywhere can access the benefits of life-saving treatment and prevention solutions. We've seen what's possible in terms of collecting and utilizing local data to inform effective local responses that drive impact. And we've seen the incredible courage, power, passion of communities and civil society that are at the center of this response. We've also seen how important how the HIV response has really shown a light on ensuring the rights of affected and infected people with the provision of access to diagnostics, preventive and treatment medicines and services have been at the core of what we do and how important ensuring those rights continue. And most importantly, we've also seen that the HIV response has transformed the health landscape in country after country, strengthening health and community systems that, yes, result in HIV impacts, but also have much broader reach in terms of broader health gains. Unfortunately, the broader global health dialogue that is occurring as we speak has failed to really remember all of these lessons that we've learned from the HIV response. We as a global community have forgotten how important these lessons in the HIV response have been, how these lessons have indeed contributed to advancing broader health gains and goals, how systems have been strengthened that result in HIV impacts, but also respond to broader health impacts and address broader health threats, reaching marginalized populations all around the world. The report we're disseminating today offers some insights into how diverse countries and communities have been innovating to build out from the HIV response, leveraging the public health and community infrastructure, as well as the core principles that we've learned from the HIV response to contribute toward building stronger health and community systems. Policymakers all over the world, we urge you to be more intentional and more purposeful in leveraging these HIV platforms and systems to create win-win scenarios for broader health systems and broader health outcomes. We must continue to push across sectors, across government, across academia, across private sector, UN agencies, communities, development partners, to ensure that the lessons we've all learned, we've all contributed to from the HIV response are indeed institutionalized in the development of strategies that are being considered for broader health systems. Through learning by doing, as we've done over the decades together, the HIV response has shown us what is possible, really turning the impossible into the possible. We've been able to respond effectively to a pandemic. And we know that lessons here are absolutely critical for broader lessons, for broader pandemics. And so UNAIDS strongly encourages countries to take on broad lessons learned from the global HIV response when developing instruments and plans for pandemic prevention, preparedness, and response. And as considerations are being made related to primary health care and universal health coverage, because what we've learned from the HIV response indeed builds stronger and resilient health systems that are impactful for people living with and affected by HIV, but also for broader communities and broader health gains. So with that, we're just really excited to launch this report. And Chris, I'll turn back over to you. Thanks so much.
Great. Well, thank you so much, Anjali. And now we're going to have a panel discussion to get country perspectives on expanding from the HIV response to broader health. Let me introduce our speakers to start off. We have Kiomia McLean, Executive Director of the Alliance for Women Advocating Change, AWAC, in Uganda. Dr. Nicola Skyers with the HIV Program Management, she's an HIV Program Management Specialist in the Ministry of Health in Jamaica. And Steve Litsike, who's the founder of Access Chapter 2 in South Africa. Thanks all of you for being with us today. A reminder to everybody who's watching to please put any questions or comments in the Q&A box, and we'll get to those after we have some Q&A with the speakers. We see in the case studies in this report that the HIV response is a force for multi-stakeholder engagement, human rights-based programming, community leadership, and constant innovations. These are strengths we need to bring to health services more broadly, including pandemic preparedness, health system strengthening, and universal health coverage. So with that in mind, let's hear some country experiences with building out from HIV programming to broader populations and services. Kiomia, let me start with you. AWAC is a feminist network of grassroots sex worker-led groups, organizations, and collectives. In January 2022, the Ugandan Ministry of Health announced an outbreak of Ebola. The value of AWAC and the broader community infrastructure built through HIV investments was amply demonstrated in responding to this new threat of Ebola. Can you tell us about how community organizations working in HIV were able to play a central role in the response to Ebola as well?
Okay, thank you so much, Chris, for the platform, but also UNAIDS and in partnerships with Elton, or with support from Elton for creating this platform.
Kiomia,
sorry, can you hear me?
Yes, can you turn your camera on?
Yes, it's on. Can you see me?
No.
Oh, really? Oh,
there you go.
Sorry.
No, yes. Very good. Good to see you.
Yeah, sorry, I didn't realize. I think it was closed somehow. Yes, I would turn on my camera for the purpose of introduction, but when I'm doing my presentation, for some reason, I will turn off my camera because my network might be disrupted. Hello, everyone. I'm Kiomia McLean, and I work with the Alliance of Women Advocating for Change. I'm based in Uganda. I works with a grassroots umbrella network for grassroots female sex work-led organizations, working with specifically female sex workers with multiple intersecting vulnerabilities. And here we talk about sex workers with living with disability, refugees, age-wise engaging in sex work. We are looking at children of sex workers who are aging or beyond 60 and above, and female sex workers who are using and injecting drugs. Just to say that, yes, our response was amplified or fueled by the support that the communities access, so that we received from WHO and UNAIDS. And we were again a grassroots consortium of 3 organizations: Alliance of Women Advocating for Change, NAFUFANO, which is a network of people living with HIV, also for the organization, different organizations, but operating at the grassroots, and traditional healers, specifically an organization called Uganda Nedagala n'ebyobuwangwa bwaffe. Sorry, Chris, it's a local word, but nevertheless you'll read from my small presentation. So we accessed this funding, and just to say also that we were inspired, or we learned from the previous COVID-19 experience, whereby when the ministry announced some of these pandemics, specifically COVID, we had communities suffer the consequences, community crying, community calling for support, but very few voices were actually heard. But also even in the planning of the implementation, that most of the communities were not actually prioritized to be targeted, to be partial, or to be considered as partners in the response. So this time around with the Ebola, the experience was completely different. UNAIDS worked with communities of our grassroots organizations using the community innovative model that we established at the time. And that was the community actors of HIV prevention that we developed at that time to basically support or empower communities to try all our innovations that we could using our grassroots community structures to respond to the epidemic. Now, we realized that, first of all, the initiative that we established was very much important, because first of all, it was implementing responses or interventions using the integration model. One, addressing the pandemic and epidemics, but also integrating the mental health component, integrating the HIV component, integrating the sexual reproductive health interventions, including gender-based violence, and the socioeconomic resilience, which was actually doing amazing to respond to some of these responses. And also because we realized that most of the districts that were affected, some of them actually were badly hit by the Ebola, and to the extent that they had to experience lockdown. But also we realized that most of the times when such scenarios happen, the grassroots communities, the people with low income, the people living in slums, in far districts or rural districts, actually suffer the consequences. So, hello?
Yes, go ahead.
So basically our title was, our title was focusing on community actors for HIV+, for epidemic and pandemic, including integrating community mental health and social well-being, HIV, sexual reproductive health, and economic resilience, which I've just talked about, but also placing an emphasis on grassroots communities for who are often ignored in such public health emergencies. Responding to these categories specifically, we were addressing key populations, more so the female sex workers with multiple intersecting vulnerabilities, and again, people living with HIV, and the traditional healers, and the adolescent girls and young women. Someone would ask, why specifically these categories? You realize in Uganda we have traditional healers. I know also in other countries, but cases of such as Ebola, many people, when they would actually interface with such a scenario, many of them, because of the limited information in the community, they would actually choose to run to the traditional healers for support, thinking that they have actually been bewitched. Now, in the process and how the virus was actually spreading, this was actually putting more people at risk of getting infected. First of all, the models or approaches used by the traditional healers in the practice of treating. It's completely, they have to use the salivas, they have to use the intentions on drinking to get, to get the blessing. They have a small pots in the shrines. So you have to register your name, to give the details. So all these practices were actually increasing the spread of actually Ebola. So it was very important. But also for people living with HIV, you realize that most of the people who are living with HIV are more prone. Why? Because their immune system is already compromised. So in the process of such epidemics, pandemics, when they are left out, they suffer the consequences. So it was very important for us also to prioritize their issues. Then cases of female sex workers. We all know that the research, of course, reading from the research that was conducted, that Ebola would stay in the semens beyond even 6 months. So you realize that during this time, information was there, but very limited. The language the information was being given was in English. Most of the people at the grassroots would hardly access or even interpret and understand this information. So this CAHIV, or the Community Actors of HIV Prevention, was an initiative which was actually developed or established to ask to be, first of all, implemented by and for communities, whereby they think of what they think can work. What is my role as McLean in the community? How do I document this information in a simple language or a drawing that I can be able to report, to document, but also share among my peers? What about the people living with HIV? What about the traditional healers? If we target them, first of all, they had the data, because everybody who accesses their shrines, they record. So it means that that seemed to be like very informal approach of documenting that information for us would actually help us to track or to give the information that, okay, if this person visited this shrine and this time, and then we have a case that has been identified in specific area of village, it would be it would lead us to another person who might also be at risk. So you realize that these were things that we really used to, one, address some of these challenges. We were able to report, we were able to train ourselves, we were able to actually even practice, like the traditional healers, document their own model of the small booklets that they will use to share this information, but also actually train our own constituencies, one, to become the actors. Most of our groups have got different other models, like, for example, the community-led monitors. Our model, the CAHIV, used some of these grassroots existing structures to actually be able to reach out to the communities, but also be able to actually spread the gospel, because these are already structures that are into existence, and definitely they are able to be able to collect the information, to spread the information with the right information without any myth, but also to empower our own communities to be able to be role models or champions within the response, to address the response. Then the other one that for the sex workers we used was the community health and livelihood. Yes, a few minutes. Community health and livelihood enhancement groups. These are safe spaces within the hotspots where sex workers convene, do the serving, and talk about such cases. So these spaces would also be used to identify cases, report cases, document these cases, so that we are able to report with clear evidence coming from our own. So UNAIDS supported us to develop, to integrate the MySQL system, which is an online system that these cases will actually directly be reported, that Ministry of Health can build on, that other partners, UN agencies, even other communities and CSO can actually build upon. So I think for me, those are some key things that we learned this experience, and I think they did a tremendous job in the response. But one big lesson that we learned, that HIV it's still a reality among us. However, it's high time that we actually add the plus. We cannot implement it as a standalone concept, but we need to integrate, because every scenario, every public health emergency that comes on us, people living with HIV are affected so much. Key populations are most affected. Traditional, of course, and other categories. So it's important for us to implement every public health pandemic emergencies, integrating it with all these other components I've talked about. Thank you.
Thank you. That was a wonderful tour of all the many ways in which the interaction of the community networks around HIV and the partnership with UNAIDS helped your Ebola response. That was fantastic. Thank you. Dr. Skyers, in Jamaica, structural factors challenge health service access, not only for HIV, but for other health priorities. In particular, hostility towards LGBTQ plus people in the country can deter many people from seeking needed health services. Can you tell us how the government has invested in community organizations to actively engage marginalized communities, including LGBTQ plus people, and how one organization, the Jamaica AIDS Support for Life, has broadened its services beyond HIV? Dr. Skyers.
Good day, everyone. Greetings from Jamaica. That's a very big question. Since the inception of the HIV response in Jamaica, the government has always worked with our civil society partners. So the question itself is like you're asking, how do you treat your family? How do you work with your family? That's basically what you're asking us, which is, standard in our context. We have partnered with the civil society over the years. There has been cross-training. So even though we're speaking about where the government has supported civil society, we also need to look at where civil society is supporting the government in the HIV response. We have partnered through the implementation of the response. We have partnered through capacity building, both for civil society as well as government partners. And as we focus on what's happening with our LGBT population, we have benefited significantly from our civil society partners with the training of public sector workers to actually strengthen the response for these particular populations, because as we are aware, the government sector doesn't do as well with the LGBT population, especially with the legislative challenges that we face. So we have always valued the input of civil society in our response in Jamaica, and we provide support, especially through our international donor partners, to our civil society agencies, so that they're able to provide the support that we are aware that the government does not do well with. So capacity building, as I mentioned before, additional resources to offer HIV services. For example, as it is now, all the HIV testing supplies that are procured through the government, they're actually provided to our civil society partners free of cost for them to implement HIV testing. We do have Jamaica AIDS Support for Life, as you mentioned, that started as the first non-governmental treatment site. And the government actually provides resources to JASL for it to offer the services to the populations which we know have challenges or barriers in terms of accessing public sector services. So it's a family relationship. I call it, it's beyond a partnership at this point in my estimation. It's really how we work together to support each other in the HIV response. So, we provide the resources to them, and they provide us with their technical capacity as well in the HIV response. Jamaica AIDS Support for Life, they have expanded. They continue to do a plethora of work around HIV, not just in terms of service delivery, but also in terms of advocacy, and really trying to strengthen the enabling environment. And again, the resources through the government supports the organization in delivering those services to the populations who need it. Thank you.
Thank you so much for that. Your comment that it's really a family rings so true. And it reminds me of someone I interviewed once about the HIV response and how it was unique in their country. And they said, for everybody working in the HIV response is a mindset. It means certain things that are about being part of a family, working collaboratively to get the results for people. So that really rings true. Thank you so much. Steve, welcome. The nationwide mobilization of community activists demanding access to antiretroviral therapy in the 2000s had a profound effect in South Africa and the whole world, inspiring activism across a range of health issues. Can you tell us how the HIV response in South Africa helped the country confront the COVID-19 pandemic and is contributing to implementation of integrated care models? Hi, Steve, go ahead.
Thank you so much, Chris. Good afternoon, colleagues. I hope I'm audible.
Can you turn your camera on? Yeah, we can hear you. We just can't see you.
Yeah, I'm just worried with the load shedding. The signal I'm in is not stable. Can you see me? Can you keep it down?
Perfect.
Thank you so much, Chris. And let me really send my greetings to my fellow panelists and representatives of various development agencies, Chris, and also to the delegates or participants of this session. I want to really start by saying that here in South Africa, we've seen the high level of various epidemics that we've constantly dealt with over the years. And all these years, ranging from HIV, TB, as well as the recent COVID-19 as a public health threat. But all this range of issues, we've managed to find our ways to navigate our work and our response in terms of how we deal with the epidemic itself, or the multiple epidemics itself. I speak here because the legacy of our history that have pushed for multi-sectorality in driving the really broad-based interventions is based on knowledge production. And we have over the years generated knowledge both from the level of scientific, social, as well as elements of structural obligations in really responding to the multiple levels. But we have used various ways or various mechanisms in responding. Not did we only depend on the work of our government, but we depended solely on our communities, which strived to really push for the community voice, prioritization of putting people, particularly people living with HIV, at the center of response. And also, when we started to redefine our own tailor-made peer-navigated effort, was based on knowledge of who are the key and vulnerable population we needed to give attention to. We have recently, just a couple of months ago, launched our national strategic plan, which is the 5th generation of our national strategic plan, which varies from prevention, treatment, addressing social and structural drivers, accountability, which really puts the multi-sectoral response into it, but also most importantly, that speaks to the resources and measuring what we put as a country, but also what we see as investment coming from outside, from major players such as the Global Fund, PEPFAR, and many other countries that stands in solidarity with South Africa. And our experience really have seen a change of lives, a change of the way we respond, but most importantly, saving lives for that matter. And those are the key highlights that we really have to prioritize, because a tailor-made intervention also speaks to that. But over the years, we've also seen organized communities learning better and doing better and serving better. And you have programs and really capacity that have stemmed even to the level of community system strengthening. And community system strengthening that really speaks to the heart base of the health system strengthening itself. And that joint approach have seen interventions such as community-led monitoring. And we have pockets of lessons and best practice lessons looking at community-led monitoring systems led by the people living with HIV, where we've seen a program such as Ruchitsi that is supported, that is led, and that is also organizing and going into facilities as people living with HIV, monitoring facility from the point of gate until the point of the service tailored by a health professional, but also what then happens in terms of follow-up. How do you make sure linkages to care? How do you make sure there's follow-up, there's adherence to treatment? Because the ultimate result here is really about how we reduce the viral load of a person who has access to treatment that is consistent, but also that is also following through into that work. And I think our own response and our own work have seen those lessons that have been achieved into the case study of South Africa in strengthening how we respond. And we've learned this over the years, over the last 45 years or the last 40 years of the HIV response. It has taught us on what we need to do on other epidemics as well. When you take TB, number one killer of South African public health issue is TB, it's tuberculosis. And we still have quite a lot of work that we need to be doing there. And I think we have advocated at civil society post-COVID, what we have called as South Africa's recovery plan, where we also not only just looking at those who are infected by TB and needs to get access, but we're also looking at the number of missing people, 200,000 missing people who needs to be linked to the screening and who also needs to be linked to treatment, and also dealing with the multi-drug and the extreme drug resistance. And that on its own, that recovery plan, the main part of it is what we mobilize, how we mobilize communities. And the last point I want to really uplift is that when COVID-19, which many of us, we did not expect, we did not see it coming, when it struck the world, we found ourselves in the crossroad in terms of what do we do and what level of interventions do we need to be working at. But I think we were fortunate because both the level of political leaders and community leaders, including the private sector, were actually ready to pull up their sleeves, pull up the socks and respond. And that level of pandemic responsiveness really uplifted that work. And I think South Africa, having had to deal with the multiple pandemics, but also having had to deal with the highest epidemics, and we were most hit, which means the response requires more effort, more leadership, more political will, but also most importantly is the resources. And we did leverage on the HIV response learning. We did strengthen our health and community system, and we responded in a way that actually speaks to the work. And I think we were fortunate when we saw the COVID response and we're dealing with it and we normalized it. Although we lost a whole lot of people, and I think it's quite important for us to realize that, that unfortunately when you have a public health threat, it comes at the cost of life. And that on its own, it's inevitable. It's really about how we reduce and we don't have the highest epidemic of people who die because we can respond better. But Chris, I want to say that our country has been very much exemplary in how we can really put together multi-sectoral effort and respond and put a domestic, including the international support to respond to the issues. Thank you so much for this opportunity and for the platform.
Thank you so much, Steve. That's wonderful. I do want to encourage folks to put any questions or comments in the Q&A box, and we'll get to as many of those as we can. We do have one now, and I'll read it to you and then ask all the panelists and other speakers are very welcome to respond, but I'm going to kind of add it in with a follow-up question I had. So the question from Thomas is, new infections with HIV are seemingly surging in sub-Saharan countries such as Uganda, Rwanda, and so on. What are you doing to ensure that the achievement registered in the past of bringing down HIV infections is sustained? So So in answering that question also, I'm wondering if you can also talk about, as you've seen how the HIV platform can be harnessed to do other things in health, as you've just discussed, were there challenges in maintaining the HIV response itself as you did other things in health, or were there synergies there that actually doing other things in health, like responding to Ebola or COVID or reaching key populations, actually there were synergies that helped you respond to HIV at the same time? So let me open this question up to our panelists. Steve, go ahead.
Chris, thank you so much for that question. I think it's a very valuable question, and that sometimes we undermine what comes with this. You would understand that in the public health response, we also rely on an enabled environment. If we do not have a proper policies in place, if we don't have a will to even introduce, even in the hard knock of criminalization. Take, for instance, the reality of sex workers in South Africa are still criminalized. But what we have seen as an opportunity is to have a secular agreement between Department of Health and the South African police and so forth, all different key players who've agreed that sex workers should not be arrested, for instance, because we do need to find sex workers. We also do need to find injecting drug users. While there was an introduction of bills like decriminalization of sex work in the country. I mean, up to date, it's been years we've been dealing with the bill because we go up and down negotiating, trying to get it off the table. And although it was passed by our NCOP in 2023, but it has still not been signed by the president, which is going back to parliament. So what I'm then pulling as a synergy is that the issue of structural or policy work, if it's not dealt with, which may take long, make a remedy to make sure that you can still respond to the issues without delaying services for people. Now, the second point, which I'll be very brief on it to allow other members to speak, is the issue of how do you bring other key players, because you cannot respond to HIV without pulling the intersectional vulnerabilities and challenges. You cannot leave behind other players. You look at the role of traditional leaders. You look at the role of traditional health practitioners. 80% of South Africans, before they go to the public health sites or clinics or hospitals, they actually start with the traditional health practitioners. So you need to then start to look at who do you need to educate, who do you need to empower to harness the response in that. So those are the two key points I wanted to lift. Thank you, Chris.
I really appreciate that, Steve. To our other speakers, any comment on, HIV continues to be, HIV infections and continue to be a challenge, and also getting treatment to everybody who needs it. So within that, I mean, were there challenges for you in terms of expanding out for HIV programming while still addressing HIV? Any further comments?
Hello?
Yes, go, Kiyomiya, please go
Chris.
ahead. Please.
Thank you so much. Thank you for my previous speaker who has responded. I'll just re-echo what he has mentioned. Sorry in court, really. Repealing criminalizing laws that really drive many communities underground instead of actually empowering them to actually come out and access the services. That has played a very huge role to actually increase, the new infections. And instead, what we are seeing in most African countries, that many of us actually are so much obsessed with laws that actually criminalizing. So we really need to repeal laws, and this role must be very responsive, but also empowering communities to actually come out and access services, or come up creatively and innovatively, developing community-led innovative models that work for them to address their response. The other thing I also have to say that we need to increase the investment in community-led innovations. we are seeing as it's really hard, and it's so painful to share this, but it's the reality that resources are really dwindling, and anything to do with actually HIV AIDS, people seem to think that actually it's no more, but the reality, it's still real, and it's actually infections are still coming up and spreading, but then the resources are completely disappearing. So this also puts us at more risk. So for now, I would call for increased investment into community-led innovations that respond to HIV AIDS. And then the other thing I would also say, put communities at the center. We have seen that where communities take lead, where communities have actually been empowered to champion, whether it's an epidemic, whether it's a pandemic, most of this has actually we've seen successful approaches happening, but also communities owning the response, but also owning addressing the epidemic or the pandemic, but also owning the response and seeing positive results. Then my last intervention is we can no longer continue to treat HIV as a standalone component, and I think I raised this. The reality is we need to integrate. We need to look at it as an intersecting, component, whether it is, when you look at, for example, the things that are affecting most of us people living with HIV, you realize that many people, the issues about nutrition, issues of lack of, economic empowerment. But if communities are empowered to actually integrate, for example, socio-economic empowerment, sexual issues of gender-based violence, issues of access to contraception. All this, if they are implemented together as and it's treated as an intersecting issue, we can be able to address some of these challenges and also maybe calm down the new infections. Thank you, Chris. Over to you.
Yeah, I really appreciate that comment. The need to increase investment in HIV, which is far from over, and where we need new resources just to reach everyone with treatment and prevention, but also look at how to integrate that response while keeping the investment in community organizations that can reach the population very widely. Any other comments from panelists or others on this question of ways to build out from HIV while maintaining the HIV response?
Sure, Chris. Just wanted to add in terms of some of the, I'm going to say, successes that we were able to achieve during the COVID-19 pandemic in particular. One of the things with the HIV response in Jamaica, it has traditionally been, let me say, ahead of the healthcare system, and therefore some of the newer technologies and innovations that the HIV program would have wanted to implement, there was some reluctance. So certainly with COVID, we have been able to scale up the use of telemedicine as part of our HIV response, and the healthcare system is also using telemedicine as part of the response now. The lessons learned from the pilots that we would have had with HIV, with telemedicine, those were used to also strengthen what the wider health system is doing in terms of telemedicine as well. The scale up of the use of self-testing, that certainly accelerated during the COVID-19 pandemic. And those gains have been sustained even as the pandemic itself has waned. We also take note of, persons with HIV, they're living longer with ART, and the NCD pandemic that we are now a part of. And therefore, as the health system is expanding and strengthening its response to NCDs, we are also ensuring that persons living with HIV as they age, we are also integrating into that response. So it's very important for integration. HIV is a disease. You're dealing with a whole person. They have other issues that are beyond HIV that we have to respond to as part of the healthcare system and as the government as a whole and civil society partners. So we have to move towards treating the whole person and not just the specific disease, because if we continue to be disease focused only, we won't reap the gains. We have hit a plateau, and therefore we have to be more holistic in our interventions. Thank you.
Wonderful. Thank you very much. We do have a couple more questions. And again, if you have questions or comments, you can put them in the Q&A box. Jonas, well, let me ask, this is a question for Steve, I think. Jonas asked, how did South Africa manage using the community monitoring and strengthening of HIV interventions while dealing with the issues of stigmatization against people living with HIV? How did you do the community monitoring in the presence of that stigma? Steve. Hello, Steve. Wait. Oh, Steve has lost signal. So let me, he's gonna rejoin here. Chewy asks a question, how do we institutionalize and sustain these solutions within existing health systems? So that really is a question for all our panelists again too, is, you know, you've talked about grappling with integrating services, with building out from your HIV platforms, keeping the lessons of HIV. How do you institutionalize that and make sure that sticks and remains, that, you know, that you keep a vibrant HIV response even as you're doing the integration? Dr. Skyers, any thoughts on that?
Sure. So, well, one of the things with the HIV response in Jamaica, in particular the treatment component, that service started within the public health system. And therefore, what we have continued to do over time is to build the capacity of, I'm going to say, all service providers to be able to offer HIV services. So it was never a standalone program. It has always been part of the healthcare system. It's the same doctors, it's the same nurses. So I think it is important, where your systems are separate, to start integrating the services through one, capacity building for those other service providers who are not part of the HIV response, reviewing your protocols and guidelines to ensure that you are integrating the necessary HIV pieces into them, and therefore you're using that for your capacity building for your service providers, so that you are able to ensure that persons are receiving holistic care. Working with your civil society partners, again, ensuring that we have high level of trust, and just being able to build their capacity as well to offer services even beyond HIV. So for example, we're doing outreach HIV testing, but then you also build the capacity of those providers to talk about diabetes. What are other key conditions in your country that you also need to be responding to? And therefore you are able to have a more holistic conversation with the persons who are accessing your services. So it goes beyond HIV. So there is the integration within those who are not offering services and building their capacity to offer it, but then also those who are HIV specific to build their capacity also to offer and engage in conversations that relate to the person as a whole and not just specifically to HIV.
Wonderful, thank you. Steve is still trying to reconnect, I think. But Kiyomiya, any thoughts? I mean, looking forward, this question of how do you institutionalize this learning? You know, looking forward, how do you make sure that in health service provision we maintain the strengths of the HIV response, even as we're thinking holistically about people's needs? Kiyomiya, are you there? Oh.
Yes, I'm here. Sorry, I was struggling to get back on my speaker. Yeah. Well, I think for me, someone has already talked about the capacity strengthening. And for me, the capacity strengthening should actually cut across, including communities. But also, it's also important for us as communities to work and lobby our government, especially Ministry of Health, to integrate some of these into, of course, the existing tools that, for example, Ministry of Health uses. So that, like, for example, we have MySQL. How can they look at such an incredible intervention and maybe take it forward. Like, for example, when we launched our CAHIV, the Community Actors for HIV+, we invited Uganda AIDS Commission to as our guest of honor, and PEPFAR. And PEPFAR, supports directly the community led monitoring tool. This is already integrated into the existing tools that directly speak to the tracker, but also to the Ministry of Health as well. So how can they also deliberate on our own community initiatives that brings out we call it the first hand or organic data that is coming directly from the community, and have it integrated into the existing Ministry of Health or government policies. Like, they can be maybe SOPs, they can be tools that we are using, and maybe if we are not like doing up to standard, so work with us to build our capacity and have our system cleaned up to produce the first quality data. I think for me that would really work to have it sustained as well. Thank you.
Wonderful, thank you. Dr. Skyers, there's a question here for you. How do you, and we just have, if I can ask you to answer in 1 minute or two, because we just have a few minutes left. How do you ensure the sustainability of the work being done in partnership with civil society organizations? Are CSOs also building out and learning from the HIV response? And what does sustainability look like for this partnership with CSOs? Dr. Skyers.
Sustainability for this partnership for Jamaica looks like us being able to maintain the core facets of our HIV response outside of donor funding. What we are working on now from the government, Ministry of Health in particular, is that we are building out our social contracting framework so that we are able to work with our civil society partners with additional funding from the government. So as it is now, the government is providing resources through its own coffers to civil society partners. However, this needs to be strengthened. A lot of it is donor supported, and therefore with the social contracting framework in place, we are able to engage our civil society partners in a much more structured way for them to be able to deliver the services around the HIV response. The civil society partners have also recognized the need to expand what they do beyond HIV to ensure their own sustainability. So there have been a lot of investments in terms of developing a resource mobilization framework and strategy for the civil society partners themselves, so that they're able to access additional funding in addition to what they would be able to access through the social contracting framework with the government of Jamaica.
Very good. Thank you very much for that. In 1 minute, I'm going to hand it over for closing to Mbalawa. But first, I just want to say thank you so much to our panelists, Kiyomi McLean, Nicola Skyers, Steve Litsiki. Thanks so much for your insights and telling us about how you made this work in your own countries. I also want to, on behalf of Friends of the Global Fight, want to thank UNAIDS for the incredible partnership on this project, and also to the Elton John AIDS Foundation for making all of this possible. We really look forward to taking this further with all of you. And thanks to everyone who's joined today. I'm now going to turn it over for closing to Mbalawa Mugabe. He's Special Advisor, HIV and Pandemics at UNAIDS. Mbalawa, over to you.
Thanks, Chris. First and foremost, we would like to express our appreciation to the speakers and panelists for their valuable contribution in this webinar on the report expanding the HIV response to drive broader public health gains in the 6 countries that were studied. The report under discussion today provides examples of how countries and communities in diverse settings leveraged HIV responses and investments to advance broader health systems for health, while at the same time identifying and acting on critical synergies to improve programming and outcomes. In closing this webinar, 3 messages from the report and from the discussion are worth underscoring. First, the report and the discussions we have had are highly relevant and are important contributions to the current dialogues about global health architecture demonstrating that disease-focused programs can have broad positive impact and can also be harnessed to advance inclusive health systems and pandemic responses. Each story in the report, and from what we heard from the speakers today, is different and unique. There's no size-fits-all takeaway message from this report. Rather, it makes the point that HIV responses are innovative, they are flexible, they provide robust platforms to advance country health systems and services that are effective and responsive and are fully inclusive. Third, the HIV response brings an ethos and approach that has proved to be central to its success and should be purposefully leveraged for integration to broader health services and also for future pandemics prevention, preparedness, and response. I would also like to say that as the world confronts multiple and complex health challenges, we hope that this report makes a case for increased investments in HIV as a pathway to contribute to broader health goals, including stronger health systems and universal health coverage. The 6 case studies have demonstrated that far from being siloed, HIV investment and programs are contributing to strengthening health systems and enhancing access to people-centered care. We thank the speakers for sharing their invaluable insights and everyone for your time to attend this webinar. And we also thank the 6 countries and the joint teams of the UN and the country directors and regional directors for supporting and collaborating in this project. And also our friends and colleagues from the Friends for this excellent project. I would also like to join Chris in thanking the Elton John Foundation for this project and the resources they provided for us to be able to pull this together. Thank you, everybody. Let me hand back to Chris for closing the meeting. Thank you, Chris.
Thank you, Mbalawa, and thanks to our speakers and everyone for being with us today. And let's keep the conversation going. Take care.